Nursing care of an infant. Let's start with assessment, and then we're going to talk about how to alter some of our interventions. So first of all, in the interview, obviously the parent or caregiver is going to be the historian. We want to begin, if we're assessing an infant, we want to begin by talking to the parents and give that child a little bit of time to get used to it. Okay, so the parent or caregiver is going to be the historian. We want to know the history of the present illness, what's happened to bring you here today, and when did that start, and what have you done to make it better, and what have you seen as the parent. Okay, we want to know the birth and prenatal history. Frequently that's related to what's going on with that baby, or at least has some influence. What does the baby eat? What do they usually eat? Are they eating the way they usually do? Have they had illnesses, injuries, or operations? Are they allergic to anything? Do they take any medications routinely? Have you been giving the baby any medications since they've been ill? And are you giving the baby any alternative treatments? Medications, herbal things like that, any alternatives? Is the baby up to date on immunizations? We want to ask about growth and development, and in that process, we may be doing a developmental screening on the baby at that time, but we also want to ask if they had developmental screenings previously. We ask about sleep patterns, about the family medical history, family structure, who lives in the house, and then we do a review of systems, just have they had any heart problems, any respiratory problems. The physical assessment should follow the interview. We want to be asking questions, let the baby get comfortable with us, and then begin assessment. Now, obviously, in an emergency, we skip that part. They don't have to trust us for us to save their lives. But if we're not saving their life right this minute, if we foster trust, it's a much less traumatic way to care for that child. We want to minimize the baby's stress and anxiety and preserve the parent-child relationship. So what we would usually do is do the interview with the child in the parent's arms, and then begin the exam with the child in the parent's arms. Do the least invasive things to the most invasive. So you're used to going head to toe, but the things that are going to upset the baby, we want to do those last. Okay. We want to incorporate play, assess growth. There are different growth charts depending on whether the baby is formula fed or breastfed. And also there are some ethnic differences in growth rates in the size of babies. And so there are some charts that adjust for those as well. Infants should be measured lying down until they're 2 to 3 years old. The head should be placed firmly at the head of the measuring board. So you measure the infant lying down with their head firmly against the head of the measuring board, fully extend their feet and measure at that point. Infants should be weighed in an infant scale. When they're little, they lie down. When they can sit, they're sitting, but never ever leave them unattended. You've got to keep your hands ready to grab in case they lean over. Head circumference is measured at the greatest circumference of the head. And then that's plotted on the growth chart, and we look for the curve. We look for where they're falling in the curve. Vital signs. For temperature, rectal is the most accurate, but we don't always really need that accurate. So it's only used when an accurate temperature is absolutely necessary. Axillary is less accurate, but it's less invasive and risky. And so for most purposes, it's enough. We can also use temporal. Pulse should be apical for a full minute. It should be 100 to 160 in a full-term newborn, and that gradually decreases as they get older. Respiratory rate, again, 1 full minute. 30 to 60 respirations per minute at rest, and that gradually decreases with age as well. Blood pressure is not always done routinely. If it's needed, make sure the correct size cuff is being used. Don't worry about learning the ranges for this because there's it changes a lot as they grow. Just be aware that it's going to be a lot lower than an adult blood pressure. Visual acuity in infants, we assess their pupillary reaction and we assess their blink reflex. We want to assess whether they follow a light or an object, and whether they look more alert or close their eyes when a light is turned on. None of that confirms visual perception. Remember, perception is in the brain. It only confirms that the eye is intact and working. Ears or hearing. An otoscope exam, if an otoscope is being used, you pull the pinna down and back a little bit. The head needs to be immobilized for safety. It should be one of the last examinations performed because they hate it. The newborn hearing screen measures cerebral response to sound. So it's like a mini EEG. It measures that their brain is responding to sound. Examining genitalia for a male baby, we're looking, are their testes descended? If they're not circumcised, the foreskin is never retracted. If they are circumcised, the foreskin remnants have to be retracted to prevent adhesions. We also want to assess the urethral meatus for location. Is it at the end of the penis? Is it on, or is it along the shaft somewhere? Female genitals, we observe for visible anomalies. We want to look at the gluteal and thigh folds. When the baby's on their tummy, we want to see, are the folds in the gluteal folds and the thigh folds symmetrical. We also look at the base of the spine for a dimple or a tuft of hair. That can be connected to spina bifida. It's not diagnostic. A lot of people have that little dimple or tuft that don't have spina bifida, so don't go telling people your baby has spina bifida, but it's something we observe for and refer. The newborn and infant reflexes are on pages 546 to 549. Again, please do not spend 3 days memorizing those, okay? You need to know what the moral reflex is and what it looks like. You need to at least have heard of, oh, that's one of the reflexes, but I don't want you to spend 3 days memorizing when they start and stop, okay? There are a lot more important things to learn about infants. In the next section, we're going to talk about administering medication and adjusting interventions for an infant.